Yes, that's it.
Okay, excellent. Thank you.
Okay. Thank you. Okay. Hi, Dr. Raffael. Our
Hello,
next
how are you?
Hi. Our next speaker is Dr. Raffaella Pilla from Italy. Dr. Raffaella Pilla received his master's degree in pharmacy at Anzino University in Chieti, Pascara, Italy in 2005, where he also served internships at Cell Physiology Laboratory and Molecular Biology Laboratory. Prior, he was Erasmus student and faculty de pharmacie in Reims, France. He received his doctorate in 2010 from Petit I don't know.
Petit Salpêtrière.
Okay, Institute in Paris, France. Also in 2010, he received his PhD in biochemistry, physiology, and pathology of muscle at Anziano University in Chieti, Pascara, Italy. He was hired as a postdoctoral scholar in the Department of Pharmacology and Physiology at the University of South Florida in Tampa. And 2 research grants funded by Office of Naval Research, U.S. Navy, and Diverse Alert Network. He has written and lectured widely worldwide. He has been involved in ongoing research at the University of South Florida with the use of ketone esters. The title of his talk today is Therapeutic Ketosis and a broad field of applications for ketogenic diet, ketone ester application and clinical updates. Okay, Dr. Pilla, we are ready for you. If you can share your screen.
Sure, will do. Thank you very much for announcing me. I'm gonna get started on that. Can you see my screen?
Yes, we can see your screen.
Perfect. Thank you very much for the introduction. I'm very happy to be here and share my research with you. I'm gonna talk about something a little different compared to the other topics that have been treated so far. Although I believe they're strictly related, especially because we're talking about heart and hyperlipidemias and blood glucose and so forth. Everything is connected. So I'm gonna talk about my personal experience in research and notably about the last period of my research experience, which is my postdoc. So I am an Italian pharmacist, so I live in Italy, but I've been working in France, England, and the United States for a long time. This talk is about my last period in the United States, where I used to work with the Office of Naval Research. Now, what do these guys do? These guys take care of missions for attack, defense, or rescue from submarines, as you can see from these pictures. And notably, we used to have the agency behind all of this is called the Office of Naval Research, which is basically the research behind the Navy. Here is the lab I used to work at in Tampa, Florida, a beautiful place. It was a place where we used to keep a lot of tanks, gas tanks, thanks to which we were able to reproduce the Navy SEALs deep dives. So I was hired by the Navy to understand mainly if there was any physiological marker that was able to predict the phenomenon of central nervous system oxygen toxicity. I don't know how many of you are familiar with diving. I am a diver myself. I dive just by pleasure, but actually there are a few things that we need to know. I'm just gonna try to summarize it up for you. Here we're breathing 21% oxygen, whereas 79% is nitrogen. I mean, roughly, if we're approximating. So basically, the 21% oxygen is fully metabolized by our body, but not that 79% nitrogen, which is accumulating into the tissues. And if we do not do any safety stop as we go back, after a dive, we have a problem in accumulation of this nitrogen. Why do we need to do a safety stop? Because we need to let this nitrogen off of our body. If we don't do so, we have this accumulation of nitrogen in the best case scenario that can happen in the joints, and this can be very painful. This also can happen on the optic nerve, for example, that can make us blind, or this can happen on our spine, and this can make us paralyzed. I mean, it can be very bad too. So imagine this translated into military missions. I mean, these guys might not always have the time to do a safety stop properly, you know, follow the procedures. So the Navy during the 70s, the 60s or the 70s started to increase the amount of oxygen to the tanks in lieu of nitrogen. So they switched from 21% up to 33, 35, and over, you know, even a higher percentage of oxygen, such as 100%. In this way, they had the chance to stay longer on the bottom, and they did not have the problem as they go to the surface to do the safety stop, because there was no need. However, there were problems related to the excess of reacting oxygen species caused by the excess of oxygen in the tanks. This can happen in two ways. I mean, in two scenarios. Now, scenario number one, during a deep dive, as you can see from this picture on the bottom, or during a hyperbaric therapy in a hyperbaric chamber. I'm going to show you very quickly what it looks like when someone has seizures, basically under the water. This is what it looks like when we have an excess of oxygen in our brain. So the guy on the left is breathing pure oxygen, whereas the guy on the right is breathing air. They're both at about 40 meters of depth. The guy on the left is telling the guy on the right that he's feeling dizzy, so he wants to take his mask off. He's taking his mask off, he's going to lose his consciousness in seconds, because he's going to have tonic-clonic seizures, such as, I mean, the same tonic-clonic seizures we have in epilepsy, in grand mal epilepsy. So the next thing you're going to see is this guy seizing, as you can see from his legs. He's having tonic-clonic spasms of his legs. He's not going to remember a single thing as he's lost his consciousness. So he's basically having a grand mal epileptic seizure. Now, this guy is not going to remember a single thing, but he's safe because he's in a controlled environment. So they're going to take care of him. Imagine this happening under the water. I mean, this is pretty much lethal, because the Navy SEAL might lose his rebreather, might lose his respirator, and this can cause death. So the Navy wanted to understand why this was happening. This is why they started studying all this phenomenon on the neurons of solitary complex, which is in the brain stem. So as I got in Tampa, Florida, the lab group used to work on the neurons extracted and isolated from the solitary complex, the brainstem. Then when I got there, they switched from single cells to whole animal cells. So we started implanting Sprague Dawley rats with radiotelemetry modules. These modules were able to give us information in real time on electroencephalogram, electromyogram, electrocardiogram, physical temperature, and physical activity of these animals before, during, and after a dive. Just to show you what it looks like after having seizures or during having seizures, the rat on the left, on the right, is going to have seizure, as you can see. See, he's having tonic-clonic movements of 4 limbs and head. See, he's sitting on his paws and he's having a seizure. So this is what we have when we ran the experiment. This is a set of data that we used to collect after an experiment. And I mean, the take-home message was that 3 to 5 minutes before the onset of seizures, in a very predictable manner, our rats presented an increase in tidal volume and in respiratory frequency, which is, tidal volume is the amount of air that a rat would breathe, and the respiratory frequency is the amount of respiration, of times per minute a rat would breathe. So these two parameters would go up right before the onset of seizure. So we communicated this to the Navy, but the Navy also wanted to know how to avoid a seizure to happen. So we started studying pretty much what the antioxidants would offer us, but antioxidants were too mild. So we moved on to anti-epileptic drugs, but can you imagine how many side effects can an anti-epileptic drug have on a healthy patient that needs just to avoid the seizure to happen? So we moved on to starvation ketosis, which looked to be much more, acceptable. Our hypothesis was, I mean, first of all, can we put any Navy SEAL on a ketogenic diet. Ketogenic diet is a diet without any sugar. So take off your carbohydrates, take off your pasta, pizza, bread, sugar, fruit. This is very stressful, especially for someone who is in a military mission. So we needed to create something in the lab that was able to induce the same level of ketosis, but without being on a ketogenic diet. And we did so through a ketone ester, which is a non-ionized precursor of ketone bodies that we were able to synthesize in our lab. So going back, at the end of the story, we needed to administer this ketone ester on our divers. So long story short, we needed to put them on ketosis. How do we reach ketosis? Through the ketogenic diet mainly. What is a ketogenic diet? As I was saying, is a diet without any carbohydrates. Pretty much we have 5% carbohydrates, 20% protein, and up to 75% fat, which is so it's a high fat diet. What kind of food can we eat? Well, basically all fish, all sort of meat, all sort of nuts, or most of nuts, butter, olive oil, but also eggs and so forth. This way we might decrease the glucose, blood glucose we have, and the insulin levels. Through some studies that have been presented in the past and published, we know that the best level, the optimal level of ketosis as now is the ketosis included in between 2 and 5 millimolar of value. Over 8 millimolar, we might start go investigating our ketosis level, because that might lead to ketoacidosis. We don't want to achieve that. Although it's quite hard as long as we have a functioning liver and functioning kidneys. Well, what is keto adaptation? What does it bring to? Are there any benefits? Well, there are many benefits. In fact, we have a decreased central fatigue, enhanced brain metabolism, reduction of reactive oxygen species synthesis, but also an increased biogenesis of mitochondria, an increased insulin sensitivity, and less lactate in muscles. You might believe that this is a new approach. The ketogenic diet is not new at all. It was discussed and published back in 1922, so we're talking about 100 years ago, from the Los Angeles Times, talking about the Johns Hopkins Hospital in Baltimore, on the other side of the United States, on the East Coast, where they used to put kids that were refractory to epilepsy medications. They were used to put them on a ketogenic diet, and they had great results. They were able to completely remove medications in 1/3 of cases, reduce their doses in another 1/3 of cases, and there was the final third that was not susceptible to ketogenic diet, but still they were able to have great results. So we're thinking that this was the first report. This was not the first report. Even Hippocrates, back in 400 before Christ, used to talk about ketosis as neuroprotection. Of course, he didn't interpret it that way. Back in the days, there was no diagnosis for epilepsy. So he discussed about, how some people were possessed by the devil. Of course, they were possessed, but most likely they were affected by epilepsy. These people were put in isolation for a few days without no food and only water to drink. So after a few days, they were able to go back to normal situation. So this meant that ketosis was probably the solution to their problem. So even ketosis was the solution for the hypothetic epileptic diagnosis. Anyhow, if you want to have any idea on how ketogenic diet works and ketosis works in our body, I strongly suggest you to go read this comprehensive review from George Cahill, 2006. This explains what happens to our body as we are onto ketosis. So about seizure protection, we found that this non-ionized precursor of ketone bodies called the ketone ester was able to achieve high level of ketosis, and this way our rats were able to resist against epileptic seizures for almost 6 times longer. This was a great result. We published this paper in 2013. And we also found that among the 3 ketone bodies that we all know, beta-hydroxybutyrate, acetoacetate, and acetone, this last one, the acetone, was the most responsible for the anti-epileptic activity. Then I moved back to Italy and I started working with Dr. Coppola and Dr. Vigiano, who in Italy are some of the most engaged experts in ketogenic diet against epilepsy. And we started working on another model called the pentylenethrazole. The pentylenethrazole, even in this model, we were able to demonstrate that ketone ester was able to increase the resistance of our rats in a consistent way. So we published 2 papers describing this phenomenon. If you're interested, these papers were published respectively in 2015 and 2016. But then I might just give you a brief idea of what ketogenic diet is good for a number of pathologies. It started off for losing weight with the Atkins diet, but then we moved on to neuroprotective effect. In fact, we have application for Alzheimer disease, Parkinson disease, and even Lou Gehrig disease, which is also known as amyotrophic lateral sclerosis. We also have applications in traumatic brain injury, so it's a neuroprotective approach. We also have glioblastoma, which is one of the most aggressive brain cancers. In fact, the theory behind cancer and ketogenic diet is in healthy cells, one healthy cell will try to consume all the carbohydrates, all the sugar that there is available. Once the sugar is over, the cell will attack the fat reserves and the ketone bodies to take nutrients. However, in cancer cells, at least in brain cancer cells, this mitochondrial adaptation is not available. So once we finish up the sugar reserves, cancer cells have the tendency to go latent, and the tumor mass tends to decrease. This is the approach. So there is a huge application for ketogenic diet in oncology, although we still have to consider every single option. And then of course epilepsy, as I was saying. But let's move further. So as I moved back to Italy, I needed some partners to allow the Italians to get rid of their carbohydrates. As you might know, Italians are very much in love with the pasta and pizza. So I needed to distract them and give them something that might look like what they used to love, but they didn't have the same macronutrient approach. The same macronutrient intake. So this company, the Gambero Ketogenic Food, was able to produce this sort of food with the same taste but different composition. So no sugar in this food. This helped me increasing the compliance for these patients and allowing them to follow a ketogenic diet in a proper way. So I've been publishing a number of videos and I put them on YouTube to explain people how good this could be for our health. I've been also publishing a number of review articles in different papers to explain that ketosis might be very beneficial for us. In addition, I've been struggling with Legambari Foods, with this company, to obtain the authorization from the Ministry of Health to distribute these products to GLUT1 patients and epilepsy patients for free. So now these products in Italy, at least in Italy, they are distributed for free. Now I'm going to talk to you very quickly about the most successful cases of cancer I've been treating within these years. This guy used to have a prostate cancer. He was treated with a mild ketogenic diet, and his prostate-specific antigen went from 1.62 to 1, which is a great result. He's been 2 years on a ketogenic diet, and his tumor mass seems to be decreased. He has no evidence of cancer recurrence, actually. This other guy used to have a pancreatic cancer. He was put on a strict ketogenic diet. His cancer antigen went from 43.69 to 9.84 units per milliliter. He's been over 2.5 years on a ketogenic diet, and he has no evidence of cancer recurrence. Also, we have this person here having a second high-grade glial lesions, brain cancer. It was put on a strict ketogenic diet. He, after 9 months, showed to have a reduction of glial lesions, of tumor mass, and of the edema. Matteo, he had colon adenocarcinoma, colon cancer, stage 4. I was put on a strict ketogenic diet and was able to, after 1 year and 3 months, was able to revert his initial condition. Then we have also some cases of glycogenosis. This guy was put on a mild ketogenic diet. He used to have pain and spasms. He wasn't able to exercise anymore. After a couple of months on a ketogenic diet, it's been pushing it for much longer. He was able to go back to work and exercise. He had no more spasm or pain. So, I mean, great results on this side too. We also had glioblastoma multiforme, one of the most aggressive brain cancer, as we said. This guy was put on a strict ketogenic diet. And after 8 months on a ketogenic diet, he had no evidence of tumor mass. Great. Every year since 2014, if I'm not mistaken, Dr. Tagliabue has been organizing in northern Italy, in Pavia, a specific course for registered dietitians to use the ketogenic diet in a number of applications. Of course, not 2020 and not 2021 because of COVID-19. Although we hope to come back as soon as possible. Now, the last part of my presentation is the application of a ketogenic diet on Parkinson's disease. What does cause? What causes the neurodegeneration in Parkinson's disease? Is a neurotoxin called MPTP. We all know that, but we don't have much literature talking about the possible application of ketosis on this kind of neurodegeneration, because one of the two main side effects of ketosis, which are, by the way, constipation and osteoporosis. So constipation might be a problem for patients affected by Parkinson's disease. So I've been looking into literature, and all I could see is that beta-hydroxybutyrate was able to neuroprotect patients with Parkinson's disease, but I mean, it was pretty much what I found in all papers, and there are not many papers on this topic. So I wanted to investigate a little more about it. So as you can see, all of them say pretty much the same thing. So I talked to these guys that work in this clinic, which is not too far away from where I live. And we've been deciding to put a small number of patients affected by stage 1 Parkinson's. So it's a very early stage, on a ketogenic diet for 3 months to analyze, to assess what will go on their speaking abilities, facial expressions, general tremor, rigidity, posture, and so forth. So we've been analyzing their autonomic dysfunction, sleep troubles, neuropsychiatric disturbances, and other problems typical from this patient. The tests we've been using have been the G-walk test, time up and go test, and the 10-meter walking test, which are very specific for Parkinson's patients. And we've been analyzing their attention, concentration, capacity of speaking, so their phonemic fluency and their semantic fluency, and their memory. Just to give you an idea of what we did, they have to remember a pattern and a path. So this is a path. They have to remember what path the physician had been choosing. And here they have to remember the pattern, the right pattern that might fit into that frame. Of course, we analyzed the reaction time and the number of things that have been interpreted in their data. Unfortunately, COVID-19 kicked in, so we couldn't finish up all the experiments. We only have preliminary data that, however, are in line with other studies. So we've been analyzing performances about cognitive decline and about motor and non-motor conditions. But if we analyze this paper, published in 2018 from Dr. Phillips in New Zealand, we find that there were so many common aspects. First of all, he's been putting 38 people on a ketogenic diet for 2 months. He found there was a decrease in urinary problems, pain, fatigue, daytime sleepiness, and cognitive impairment. All of these got much better after 2 months on a ketogenic diet. Well, we found the same results in urinary problems. We couldn't go farther, as I said, because we were supposed to go for 3 months on a ketogenic diet. We only went up to 1 month, and then COVID-19 kicked in. So the most important thing that Dr. Phillips demonstrated in this paper from 2018 is that the ketogenic diet is safe to be followed even for over a few weeks. So we organize a number of social events such as Run for Parkinson. We involve people affected by Parkinson and their families to get together and find the solution. So our next step right now is to apply the ketone ester, our non-ionic precursor of ketone bodies, straight to our patients without putting them on a ketogenic diet. I want to thank the Italian GLUT1 Association with its president Massimiliano Barone, but also RareConnect.org, which allows people and families having a rare disease among them to meet other people with the same disease. And this way they could follow, they could get together and find a way to solve the problem together. Then I have to thank Dr. Cosimina Cusano, who is the physician, helped me treating so many patients with a huge variety of pathologies. And the very final point of my presentation is that I would like to introduce this movie, Fed Up, which explains that probably if things do not change back in 2050, 1/3 of the adult population in the United States would be affected by diabetes type 2. So this is interesting to understand how sugar can be bad for us. This is another movie from 2015. Is main character is from Australia. He's been undergoing a number of sugar-related tests, explaining, showing how bad sugar can be for our health. This is the magic pill out in 2017 in the United States. This explains how easy it could be to manipulate our health status. So it is, in my opinion, a very good movie. And finally, this one, Butter Makes My Pants Fall Off, which is a homemade movie that explains how this guy went from that pant size to a lower pant size, just eating butter and fat. So I would like to thank my European colleagues, my Italian colleagues, but also my American colleagues and collaborators, as I'm really grateful to them to introduce me into this world. And if you have any questions, please do not hesitate to ask. Thank you, Doctor. Thank you. Yeah, and as you wrote in the comment chat, if you have any questions you want to ask even afterwards, you might email me. I'd be happy to receive and answer your emails.
Thank you so much. That was an amazing and interesting presentation.
Thank you.
So, yeah, you're. Okay, I have to ask, is if Dr. John Mezaka is ready? Hello, Dr. Mezaka, are you ready? Okay. Okay, we thank you so much for being with us. So far, we are going on a 10 minutes break. Okay, if Dr. John. We will be back with Dr. John later. Okay, so we are going on a 10 minutes break. Thank you, everyone. Dr. John. No, we can't hear you. I think you are on mute. Okay. Hello, everyone, and welcome back. This is Cardiology Webinar Day 2. We are here with Dr. Mutaya Ramchandran. Okay, Dr. Ramchandran, can you hear me?
I think he's over phone, but
Yes, I think he's on the phone. Okay, I'm gonna introduce Dr. Ramchandran in the meantime. Dr. Ramchandran Mutaya, consultant physician and cardiologist in Morningstar Hospital in India. He completed his MD in General Medicine in 1996, DM in Cardiology in 2003 under Tamil Nadu at Dr. MGR Medical University in India. He worked as medical officer in rural health services for 5 years and in teaching category as assistant professor at Madras Medical College in India. He published many papers in Cardiosource, American College of Cardiology Foundation, case reports in Clinical Medicine, and Journal of Saudi Heart Association. His special research on rheumatic fever and endocardial fibrosis in tropical belts myxomas, infective endocarditis, apical hypertrophic cardiomyopathy, Ebstein's anomaly, rheumatic tossing pink heart, Costello syndrome, and tetralogy of Fallot. The title of his talk today is Tossing Pink Heart. Dr. Ramchandran, if you can hear me, can you start your presentation? I see you are having a problem with your audio.
hello, Dr. Ramchandran. Hello.
Dr. Ramchandran, if you can connect your audio.
Hello. Hello, Dr. Ramchandran. Hello, Dr. Ramchandran.
Mr. Krishna, I think he's having problem with his audio. I see it's not connecting.
Yeah, there might be network problem, I think.
Okay, can we move on with Dr. John? I think
Yeah,
he's
I think if he's ready, John, we can move ahead with John.
yes. Dr. John Mezaka, are you ready?
Are
You are on
ready?
mute. You are on mute.
Can you hear me?
Okay, I think we are back with Dr. Ramchandran. Dr. Ramchandran, hello?
No, I think John here.
It's
It's John, I think.
Okay, yes, John is here. Yes, we can hear you, John.
You can hear me?
Yeah,
Yes.
yeah.
Okay, because I'm somehow having trouble with my computer, but I can do it on my iPhone.
Right.
Okay, it's okay. We can hear you clearly.
Okay, if you can put my slides on, I would appreciate it.
Sure, I can put your slides on.
Okay.
Give a brief biography of you to our participant. Dr. John Meizaka was born in Hawaii, received degrees from Harvard College and Boston University School of Medicine, did his medical residency at Barnes Jewish Hospital at Washington University in St. Louis and Mount Sinai Hospital in New York, and renal fellowship at Mount Sinai Hospital. His interest-driven decision to spend 5 years exclusively in the renal physiology laboratory at Mount Sinai Hospital as a renal fellow and member of the faculty proved to be the best investment he made to pursue an academic career in medicine. He was involved in developing a colorimetric method for the determination of uric acid and phosphorus in blood and urine that were applied to studying the transport characteristic of both electrolyte and by renal micropuncture techniques in rat kidney. He developed several bioassays to demonstrate the presence of a natriuretic factor in the blood of patients with renal salt wasting and Alzheimer's disease, and more recently, identification of elusive natriuretic factor after more than a 25-year pursuit. The title of his talk today is High Prevalence of Renal Salt Wasting, or RSW, identification of novel protein causing RSW and introducing new syndrome of RSW in Alzheimer's disease. Okay, Dr. John, I'm going to share my screen to your presentation.
He's going to do everything, okay?
Okay, can you see your screen?
Yes, I can see it. Wow, wonderful. Thank you. Now, how do I advance?
Okay, just start your presentation, and if you want to go to the next slide, you can tell me, yes, you can tell me. I will go to the next slide.
Okay, next slide, please.
Okay.
Well, thank you, everybody. Well, we finally got on. This is a very difficult topic to talk about, more so with non-nephrologists. But we are, the problem of hyponatremia is going through a very, very difficult time right now with a lot of new changes. And there are a lot of misconceptions that are in the literature. So one word of caution is you have to be very careful when you read papers about hyponatremia, and hopefully we'll try to clarify some of that in the discussion today. Now, hyponatremia is defined as a serum sodium of less than 135 millimoles per liter or milliequivalent per liter. It is the most common electrolyte abnormality occurring in 10 to 15% of hospitalized patients. And chronic hyponatremia increases osteoporosis, and it causes very severe osteoporosis. And most hyponatremic patients are asymptomatic. And if you can see here on the slide, that when the sodium is 124, and you can sort of graphically see how they walk, you can see they act as if they are inebriated. But when the sodium is corrected to 135, they walk practically a straight line. So there is a fourfold increase in falls and fractures, and it is like a perfect storm. They are unsteady when they walk, and they fall with osteoporotic bones to increase the fracture rates. So there is a trend now to correct all patients with hyponatremia. And the problem is that you must accurately determine the cause of hyponatremia, as it will evolve as we move along here. And it also increases morbidity and mortality. Next slide, please. Now, as I said, it's really in a state of extreme confusion. So let's look at the traditional approach that has been in existence for over 50 years. They are either euvolemic, they are, it's mainly as SIADH, or the syndrome of inappropriate antidiuretic hormone secretion, which is very commonly known by so many people. Or you have hypovolemic hyponatremia, for which cerebral salt wasting is a common phenomenon, and hypervolemic, as many of you will see in patients with heart failure. There is, and has been for many years, a universal agreement that we cannot accurately assess volume, and especially in patients with cerebral salt wasting syndrome, which we will address as an inappropriate term to use. Now, SIADH is also more water-loaded as compared to dehydrated patients, and ADH, as you know, increases water reabsorption in the kidneys to dilute the blood and cause hyponatremia or lower the serum sodium. Next slide, please. Now, the volume studies, however, show that patients with SIADH are uniformly increased. So the term euvolemia is wrong and technically inappropriate. The original study by Schwartz et al. In 1957 showed by sulfate space that there was an increase in extracellular volume, the chloride space in experimental SIADH, and the gold standard radioisotope dilution method of 51 chromium labeled red cells and RISA showed that volume is increased in so many patients that have been reported, including some of our studies. Next slide, please. So that's an inappropriate term. So the question is, why focus on SIADH and cerebral salt wasting syndrome? The blood volumes are very different. If you look at the center box, it's normal. And in SIADH, the red box, it shows you the increase in blood volume that has been repeatedly recorded and documented in patients with SIADH. So they are not euvolemic. Whereas in so-called cerebral salt wasting syndrome, the red box shows you that they are volume depleted. So it's very important, therefore, to differentiate salt wasting from SIADH because they are actually treated differently, where you fluid restrict a water-loaded patient with SIADH, or you give saline in patients with cerebral salt wasting syndrome. Next slide, please. There's also an unfortunate algorithm, a number of them, to identify SIADH and salt wasting by looking at urine sodium. Many of these algorithms say that you think of SIADH or salt wasting if the urine sodium exceeds 30 or 40 milliequivalents per liter. And the question then is, if urine sodium is less than 30 or 40 milliequivalent, does that mean that they don't have SIADH or salt wasting? Which these algorithms seem to imply. So what we have arrived at is a diagnostic dilemma. And in terms of the status of cerebral salt wasting syndrome, it is considered rare. And if you look at your textbooks of nephrology, medicine, and many review articles, it's all SIADH, and salt wasting is considered rare. At one time, it was felt to be non-existent. However, it's been regarded as being common amongst neurosurgeons, critical care physicians, and neurologists. So there is, therefore, a diagnostic dilemma that exists and has been in existence for many years. Next slide, please. There is an unappreciated fact that there are identical parameters that identify SIADH and salt wasting. And these are common parameters. Both are characterized by an association with intracranial diseases. They are hyponatremic with concentrated urine sodium usually exceeding 30 milliequivalent per liter. normal renal, adrenal, and thyroid function. They are non-edematous. They are hypouricemic with increased fractional excretion of uric acid. And the only difference is really the volume status. And as we said earlier, you can't tell by looking at a patient whether they're volume depleted or not. So there is, therefore, a diagnostic and therapeutic dilemma where you fluid restrict SIADH and give salt water to patients with salt wasting. And this is not very well appreciated. So let's look at volume studies in neurosurgical patients that have been in existence for a long time. Nelson showed that of hyponatremic patients with different forms of neurosurgical diseases, 10 out of 12 were volume depleted, or 83%. In Vedic's studies of subarachnoid hemorrhage, which is commonly felt to be due to salt wasting or have salt wasting, in 8 out of 9 hyponatremic patients were volume depleted. And even in normal natremic patients, 8 out of 12 were found to be volume depleted. And a study by Sivakumar of different causes of neurosurgical diseases, 17 out of 18 had decreased blood volume. So cerebral salt wasting is much more common than SIADH in neurosurgical and critical care patients. And as we said, SIADH are hypervolemic. So if they call your patients with subarachnoid hemorrhage to have hyponatremia, and due to SIADH, Vedic's has reported that the volume restriction, these patients have been proven to be harmful, and there's a wealth of data and publications on this subject where volume depleting, salt wasting patients increase ischemia and morbidity and mortality. So the standard therapy now for these patients is to give saline. So as I said earlier, there is a diagnostic dilemma because of inadequate criteria to differentiate SIADH from salt wasting. The perception that salt wasting is rare, as noted in the textbooks, as I mentioned earlier, and a failure to recognize identical clinical parameters between SIADH and salt wasting. And there are some patients that will say they got SIADH because they're hyponatremic, normal renal function with concentrated urine and high urine sodium. That's not enough. And of course, the therapeutic dilemma, which we keep talking about. Next slide, please. So what happened was that we decided to have a new approach to hyponatremia, and we abandoned the outmoded volume approach and had a more physiologic approach where we studied fractional urate excretion rates and infusion to say differences in saline infusion responses in SIADH and cerebral salt wasting. Next slide, please. And just a few comments about uric acid. Uric acid is exclusively presented in the transported in the proximal tubule by reabsorbers and secretors of uric acid. However, if you can see here on the left, the glomerulus, it ultrafilters the blood to increase or to cause a filtrate of the plasma, and urine is formed there. And in the proximal tubule, on the left below, before the loop, between 89 to 96% of the uric acid is reabsorbed, so that only 4 to 11% remain in the proximal tubule. So what is happening in the final urine on the right lower corner is that the fractional excretion rate is 4 to 11%, meaning that 4 to 11% of the uric acid that is ultrafiltered at the glomerulus is excreted in the final urine, where it therefore reflects what's going on in the proximal tubule. And this is important to remember for future discussions. Next slide, please. Now, what we did was perform FE urates in hyponatremic patients, and we have many publications where we have the data to provide this algorithm that we created. Now, if you have a normal FeU rate between 4 and 11%, you see this in psychogenic polydipsia, which is very common and easy to diagnose because of the amount of water that they drink. And we published a paper on this. So they have a normal FeU rate. And in reset osmostat, which is very surprising, that we've now published many patients, probably 30 or more patients with reset osmostat with normal FeU rate, where they also spontaneously excrete a dilute urine. And you will not see a dilute urine in hyponatremic patients except for the psychogenic polydipsia and reset osmostat. And if they have a normal FeU rate and just a dilute urine, that is really diagnostic of a reset osmostat, or just having a dilute urine is enough to make the diagnosis. If you have less than 4% FeU rate, you'll find this in pre-renal azotemia. And this is a group of patients who are volume depleted that is not with normal kidney function. So they may be vomiting or having diarrhea. And the proximal tubule, when they're dehydrated, increase uric acid excretion rates to decrease the FeU rate. In congestive heart failure, cirrhosis, nephrosis, these are the hypervolemic causes of hyponatremia. And because they are also in part pre-renal, they have an increase in uric acid or solute reabsorption in the proximal tubule to decrease the FeU rate. Addison's disease, this is a very important contribution that we just published recently on this. And I've been looking for Addison's disease for many years because, as it turned out, we were correct in predicting that the FeU rate will be low because the transport defect is mineralocorticoid deficiency, where it acts in the distal tubule. So you are salt wasting from a defect in sodium transport in the distal tubule with an intact proximal tubule. So the dehydrated state will increase FeU rate and therefore, decrease FeU rate by increasing uric acid reabsorption in the proximal tubule. Now, people say that it's very difficult to make a diagnosis of Addison's disease in hyponatremic patients. And there's a good reason for it, because there is probably double the number of patients with Addison's who present with hyponatremia, with only about 34% having hyperkalemia, which is a very important feature of this. So in the absence of hyperkalemia and hyponatremia, an FeU rate should make you think of Addison's disease and evaluate them. So we feel that FeU rate can be a very important contributor to making the diagnosis of Addison's disease. The one on the right, where FeU rate exceeds 11%, is a very interesting part of this algorithm, where the hyponatremia, when they are hyponatremic, they have a high FeU rate in both patients with renal salt wasting and SIADH. However, when you correct the sodium and FeU rate goes to normal or less than 11%, it is consistent with SIADH and hydrochlorothiazide. And it appears that SSRIs are falling into this group, although I don't have the data to put it into this algorithm. If the FeU rate remains elevated over 11%, it is consistent with renal salt wasting or cerebral salt wasting, but notice the transition being made to renal salt wasting, which we'll amplify later on. So I think that, next slide, please. So to put it in simpler terms, on the left column, the shaded area is a normal range, and the dark, the black is the sodium, where it is hyponatremic, and in SIADH, and the FEU rate in red is increased. However, if you look at cerebral salt wasting syndrome, they appear to be identical, where they have high FEU rate when they are hyponatremic. However, if you correct the sodium, FEU rate goes to normal, returns to normal in SIADH, but remains persistently elevated in salt wasting. Next slide, please. We also found that in patients that have FEU rates greater than 11%, if you give them isotonic saline, they will dilute their urine in renal salt wasting, probably 15 hours or so or more after you initiate your saline infusion. However, the urines remain concentrated in SIADH, and this has been shown to be present in a number of our publications, and it is well known that saline does not correct the hyponatremia in SIADH, and that's been known for 50, 60 years. So saline, isotonic saline infusions is one way by which you can differentiate SIADH from salt wasting. Next slide, please. So we published a paper, and this is perhaps the best illustration of renal salt wasting in a patient with a hip fracture without cerebral disease. The FEU rate was 29.6%, very high, and the patient had decreased volume as determined by radioisotope dilution technique, but had a urine sodium of only 6 milliequivalent per liter. And the problem is that this patient was thought to have SIADH by a previous physician who water restricted this patient for about 10 days, so she stopped eating. She also had high renin and high aldosterone, along with high ADH levels at baseline when she was first seen. As you can see from this slide, the blue circle dots are urine osmolality, and the red is the serum sodium. And you can see that at the end of about 13 hours, the urine osmolality or the urine became dilute. And we measured ADH level at this time, and it was undetectable or zero, which is consistent with appropriate ADH secretion, which I'll discuss in a minute. So as you can see, when you dilute your urine, you are taking pure water out of the body and putting it into the urine. So the sodium concentration goes up, and it's corrected within 48 hours to 138. And the FEU rate remained high as compared to returning to normal in SIADH. So this is a wonderful paper that we can claim that urine sodium doesn't mean very much when you actually have very strong data of the diagnosis of SIADH. Next slide, please. And here you can see the regulation of antidiuretic hormone secretion, where if you look at the black bar on the right, and as it decreases, as you increase water reabsorption, or I'm sorry, increase water intake, the patient will become hyponatremic, and antidiuretic hormone will go to zero, as seen in the black dots at the bottom of the slide. However, if you are volume depleted, as noted in red, you will see antidiuretic hormone levels increasing progressively as you become more volume depleted, and you can remain hyponatremic as in the bottom dots there. So the volume stimulus is more potent than the osmolar stimulus. So if you're volume depleted, the ADH is being stimulated by the volume depletion and they become hyponatremic. So if you give them saline, then you move the red curve over to the right and you eliminate the volume stimulus. So the coexisting hyponatremia or hypoosmolality will inhibit ADH secretion and the urine will become dilute. Whereas in SIADH, this does not happen. Next slide, please. We also published a paper of a patient with pneumonia without cerebral disease and showed the identical characteristics of a saline infusion where they dilute their urine and predictable correction of their serum sodium. And this was entitled More on Renal Salt Wasting Without Cerebral Disease, to highlight the absence of clinical evidence of cerebral disease causing salt wasting. Next slide, please. And we published also 2 patients proven to have SIADH by measuring the radioisotope dilution methods of an increased blood volume in 2 patients. And as you can see here, the black dots reflect the continuing presence of a concentrated urine, and serum sodium does not get corrected as on the right column where the sodium remains low while the patient is being infused with saline. And they had, so this now confirms previous data to say that saline does not dilute or correct the hyponatremia in patients with SIADH. And you will see papers published where subarachnoid hemorrhage patients corrected the sodium within 3 days. This is not SIADH, and they called it SIADH in subarachnoid hemorrhage. So you have to be careful when you read these papers because there are many misconceptions. Next slide, please. So we then published a paper recently of 62 hyponatremic patients from the general medical wards of the hospital, and not from intensive care units where there's a lot of salt wasting. And we found 17 to have, or 27% to have SIADH, where they normalized the FE urate in 8, and 11 had no response to saline infusions, as we discussed earlier. We found 19 or 31% to have a reset osmostat, all with normal FE urates, 9 with spontaneously excreted dilute urines. And this percentage is virtually identical to that found by others when they looked at patients with hyponatremia. And surprisingly, 24 had renal salt wasting, or 38%. 21 had no clinical evidence of cerebral disease. So why are we calling it cerebral salt wasting? 17 had isotonic saline-induced dilute urines. 2, we proved that ADH levels were undetectable when the urine was dilute. 11 persistently increased FE urate after correction of the hyponatremia, and 10 required D5W to prevent too rapid correction of serum sodium to prevent osmotic demyelination. And you know, if you don't want to correct the sodium by more than 5 or 6 milliequivalents per 24 hours. So you can do it, if it does do that early on, you can prevent that by giving D5W. Next slide, please. So there is a large number of patients of renal salt wasting without cerebral disease. So Kidney International asked us to write a mini review entitled, "Is it cerebral or renal salt wasting?" where we propose eliminating the term cerebral salt wasting in favor of renal salt wasting. And people are saying this was a moot point, but it is no longer a moot point because 38% of these patients had salt wasting. And it becomes a very important problem in terms of treatment. So we now have proven that there is indeed a significant diagnostic dilemma, which is creating a therapeutic dilemma. Next slide, please. What is interesting is that the urine in this study, urine sodium was less than 20 milliequivalent per liter in 2 of the 17 with SIADH, 5 of the 19 with reset osmostat, and 9 of 24 with renal salt wasting. So where's the algorithm applicable when they say it's got to be over 30 or 40? So urine sodium is of limited value when evaluating patients with hyponatremia. Next slide, please. Now, if you look at this slide by Robertson, there are 4 subtypes of SIADH. Type A is a classic salt wasting, SIADH patients. Type C is your reset osmostat. That if you drank enough water and dilute your blood, you will cut off ADH and you will eventually dilute your urine. And we proved this by doing some water loading tests in patients with reset osmostat. So it's like a thermometer. The thermometer is pushed to the left because the shaded area is the normal. Type B is probably renal salt wasting. And type 4 is when you have a downregulation of the receptor of ADH. So type C, we're saying type C is most likely different from typical SIADH because they have a normal Fe urate. And it may prove to be important to separate both the reset osmostat from SIADH, although the treatment is the same to water restrict them. Next slide, please. So in conclusion of the clinical study, SIADH and RSW have been identical clinical parameters. Renal salt wasting without cerebral disease is very common in the general medical wards of the hospital. So we need to change cerebral to renal salt wasting, which is extremely important. Reset osmostat is not a subtype of SIADH because they have different physiologic characteristics, and their differences may become important in time. So because of this, you need to redefine SIADH, because the definition of SIADH is that they have urine sodium osmolality of over 100, which doesn't make any sense at all because they are including reset osmostat in it. And I think that saying that the urine has to be concentrated, meaning the urine osmolality is greater than the plasma osmolality, to define SIADH. Urine sodium is a limited value in hyponatremia, and the increase in morbidity and mortality associated with hyponatremia may in part be iatrogenic because these 38% of patients with renal salt wasting would probably have been water restricted for a misdiagnosis of SIADH based on the fact that the textbooks are saying it's rare. Now, we then, many years ago, because that's how I was brought up, that you've got to look for cause and effect. And we proposed that these patients had a natriuretic factor that was circulating in their blood. So I infused rats with the plasma of patients with different neurosurgical diseases and found increased sodium excretion rates in 21 patients with neurosurgical diseases and 18 patients with Alzheimer's disease. They both had identical physiologic characteristics in the rats by increasing sodium and lithium excretion rates, which I'll go into later. But at that time, we attempted to identify the protein, but proteomics at that time was at an infant stage. And when this proteomic analysis improved over time, we decided to try to identify the protein. Next slide, please. So in the same rat clearance studies, we injected renal salt wasting patients' sera into rats in a patient with subarachnoid hemorrhage and Alzheimer's disease. And we found after many attempts at identification that it is haptoglobin-related protein without signal peptide. It is interesting that some of our early studies showed that the signal peptide, presence of the signal peptide did not have natriuretic activity. And there's a long story about signal peptides, which is quite interesting. And here we showed that HBr, when we had it produced for us without the signal peptide, there is a very nice dose response curve as noted, and a robust increase in sodium excretion rate in red, and the urine flow rates also increase in blue. So there's a very nice dose response curve. Next slide, please. So if you look at these sodium and lithium excretion rates on the left box, that, as we said, 70% of the sodium and lithium are reabsorbed in the proximal tubule, meaning there's a 1-to-1 sodium and lithium reabsorption. It's handled identically in the proximal tubule in the absence of osmotic diuretics. And 30% of sodium and lithium remain in the proximal tubule. Now, in the right box on the right-hand side, the sodium gets transported in the distal nephron. So the sodium excretion rate is 0.2 to 0.3%, whereas lithium is identical to what remains in the proximal tubule as 30% because it is not transported in the distal tubule. So lithium excretion rates will give you a very good idea without having to do renal micropuncture studies to study sodium transport in the proximal tubule. Next slide, please. Well, if we look at the sodium and lithium excretion rates in the control, which was 24.4%, and in Alzheimer's disease, my goodness, the lithium excretion, sodium and lithium was 52.2% remaining in the proximal tubule. And under the control situation, the excretion of sodium was only 0.1%, meaning that 24.3% was reabsorbed in the distal tubule. But in the Alzheimer serum, the Fe sodium was only 0.52, which means that 51.x number percent was reabsorbed in the proximal tubule for sodium. But it shows that there's a huge distal reabsorption of sodium in the presence of the natriuretic factor. However, if you look at patients with heart failure, the proximal tubule increases solute reabsorption where Fe urate is less than 4%, as we said, but so is sodium and phosphate, etc., are reabsorbed all in the proximal tubule in heart failure. So you give a distal diuretic, you will not be able to increase sodium and water excretion rates under these conditions. But if you give our protein in combination with the distal diuretic, you can have a profound diuresis, and we can eliminate all the excess fluid and heart failure and to improve outcomes. And we intend to investigate this in the future. Next slide, please. I think the applications of HBr without signal peptide is we use it as a biomarker to differentiate SIADH from salt wasting. Our studies are underway on first encounter, so you don't have to go through all the different manipulations to try to differentiate one from the other. We need to develop an inhibitor to the protein, because if you give saline to a patient with salt wasting, they're up all night. They're urinating every hour, 2 hours, depending on how much sodium you give. So we need to develop an inhibitor to improve quality of life. We can treat heart failure, and we have now, we may be able to use it as a biomarker to define a new syndrome of renal salt wasting and Alzheimer's disease, and a large potential group with normal sodium levels, because they don't they are not hyponatremic. So this is one of the things that we have come up with, is that you don't have to be hyponatremic to have renal salt wasting. And there's a large number of unidentified groups of patients, because now with subarachnoid hemorrhage, they are treating them routinely with saline, and you got to drink water in order to develop hyponatremia. So we are in the process of trying to do some blood volume studies at this time and correlate that with HBR without signal peptide levels in Alzheimer's disease. And I feel that it's probably very common. I think I'll end here. And no, I won't. I think we're out of time to discuss this. All right.